Are we live?
Let's go.
Okay, this is the case of a 42-year-old lady. She has diabetes type 2 for a number of years. She's under current medical treatment with metformin 1000 and Ozempic 1 milligram. And she's been having actually dyspeptic symptoms, I guess, since childhood. We're going to clear out the stomach real quick because she gets some liquids in there. And started Ozempic about 4 years ago. She initially lost weight. She didn't use this for weight loss, but really for treatment of the diabetes. At least that's what she told us. And again, her dyspeptic symptoms increased once she started the Ozempic. Again, she's also on metformin. She was scoped by Dr. Schaufelberger previously, who saw some food residues, in the stomach, and now asked us to do a FLIP to evaluate her pyloric function, number one. She also does have reflux symptoms, which are treated with Dexilant 60 milligrams once per day. She's pretty well controlled in her reflux. Under that, she had Pantozole prior to that, plus ranitidine when it was still available here, which didn't do the trick really. So she does profit from the high dose, delayed release Dexilant apparently, but she still does have some volume coming up, and also she had chronic cough, which resolved under the Dexilant, interestingly. Okay, so this is small second, third part of the small bowel. I always do a standard endoscopy before I do anything, and I'm going to make some pictures for completeness, I suppose. But again, she was scoped before, so I can really focus just on main findings. The pylorus to me appeared rather closed when I looked at it the first sight. Let's look at it again after going through it. Dusty, what do you say?
Yeah, looks a bit tight.
Looks a bit tight. Certainly not on the large side, right? I mean, it's rather smallish, and you can see that I even left a little bit of a scratch going through there. I can't really say anything about the redness of the antrum. It does appear a little bit red to me, but this is Fuji, and both Dustin and myself, we are used to other equipment. Oh, it's Pentax, sorry.
Oh.
There we go. This looks more like we know it.
Yes.
And I would say, yeah, maybe there is a little bit of in the antrum of a little bit of stripes going towards it, but nothing really major, right?
Mm-hmm.
So let's look at after having cleared out the liquids. I didn't see any food residues, and she's been without eating since yesterday. So let's look at the hiatus. This is something that we gastroenterologists should do a little bit more and longer, right? Looks pretty good though. There's no overt hernia here visible. I would still give this Hill grade 1. What do you think, guys? 1?
Yeah, it's definitely some.
Maybe a little bit. It doesn't really open through respiration.
It's a little bit through it too, but
it's
yeah,
a little bit.
Not a 3 though.
A little bit effaced, but it's not really a 3, right? Well, let's play it and let's look at the FLIP later, right? Because that sometimes gives us a different picture.
Mm-hmm.
So I'm going to take out the air. And look at the Z line again. Well, again, the hiatus seems to be rather close to the Z line. There's some very small alterations to the Z line, but nothing super overt. Everybody agree? Okay. Going back slowly through the esophagus. She doesn't have dysphagia, just reflux symptoms, and again, our chronic cough, which was resolved under the PPI treatment. This may be actually a papilloma, huh?
Yeah.
Mm-hmm.
Okay. So, looking for inlet patches and other. Maybe another one. Possibly, huh? We need to take them out or biopsy them at least. I don't know how you do it, but in younger patients, I re-screen for papillomas after 3 years or so. And I didn't see an inlet patch, A little bit quick on the upper side maybe. And yeah, this looks fine, getting some of the saliva out. Okay, I think we're ready, huh? For the flip. So I guess there are different techniques how you do this. Dustin is zeroing the pressure again at the height of the patient.
Yep. So, yeah, so I always hold it atraumatic and try to be level and equal. And because there's only the one pressure sensor, I'm always a little bit anal about it. And I usually will pressure zero it a few times just to make sure we have a good baseline. And then, then I generally would lube up the catheter before placing it. I don't know if you have a gauze with some lube.
Get some lube. Ich brauche nochmal ein bisschen Gel, a little gel. Yeah, I agree to the loop. There's some people that say they don't loop. I use a little bit of loop. I like to place the scope at the same time. I don't know how you do it. I guess there's different ways of doing it.
Yeah, I usually just
I do it blindly down, right?
Yeah, I usually place it blindly down. Sometimes I'll actually put my finger in to hold the tongue down, and even with my finger, I can sometimes kind of guide it one way or another to help direct it. And then, do you feel it like you pop through?
Yeah, so this is, I can push it all the way down, or what I like to do is I go behind it, just to make sure we are both very confident that it was right in because she didn't cough, right? And then I like to advance the scope and the flip at the same time because that reduces the traction. And I'm pretty sure that we are well located.
Yeah. So I usually don't take a look and instead we'll rely on the flip. Yeah, so I'm starting to fill now, so I hit our inflate. And one nice thing about the flip is that you do get that real-time imaging of position. So even as we start to fill here, you'll see a waist will start to form at the EGJ. And we can really direct it based on that positioning as we're going. And then Danielle, protocol-wise, I usually, with this, we have the EF322 here, so the 16 centimeter flip. And with that, I'm usually positioning at the 40 ml fill volume. Obviously, kind of keeping an eye on this EGJ waist as it's filling.
Is this water or air perfusion in this?
So there's water in, so it's fluid with a known conductivity that's in the syringe here, and that fills. And so even here we're at a nice position with the EGJ. You actually already see some nice antegrade contractions. I don't put much stock in the 40 ml fill volume though, so I typically go to 50 relatively quickly.
So you begin with 40?
Just for positioning, so seeing the end of contractility. Whoop. All right. Yeah, so even already here, really nice, these antegrade contractions. So this is that normal pattern that we see of secondary peristalsis occurring in response to this sustained distension. Typically you'll see these nice antegrade propagating waves.
Does the contraction depend on the velocity you inflate it? Or?
When
you inflate the balloon
the filling is all controlled within the flip device, and so it fills relatively slowly.
It's 1 milliliter per second, and that's standardized. You cannot change it.
Yeah.
It inflates 1 milliliter and it deflates 0.5.
Yeah.
So that's
it's pretty standard.
Quickly too. That's why I asked.
Okay.
And the best volume to see the contraction waves is 40 milliliters?
No, 50, 60 are usually the times that you'll see the contractility.
Is hiccups due to
The hiccups, due to a little bit of, the distension at the diaphragm can sometimes cause little hiccups. You actually often will see this pattern related to hiccups, that little pressure spikes. And sometimes too, you also do actually kind of that disrupts the contractility. So not actually terribly surprising to see that occurring.
So well, this is why I like to start with a 40, because the more volume, the more is the irritation to the phrenic nerve, right? Which is what we're seeing right now. The good thing is we already saw the RACs, right? The repetitive antegrade contractions.
Yep.
So we are rather comfortable, I would say, with probably this is going to look good, right?
Yep. Yeah.
And the EGJ here, you can actually still see that, as well as we cannot really see the high it is, but probably it's at the same level. Well, she doesn't have a hernia for now. Let's wait.
Yes.
And obviously those are dry swallows.
Well, these are actually not swallows. So this is this is secondary peristalsis. So we can actually visualizing the patient right now. And I don't see any glottal movement or any sign that she's actually swallowing. So this is purely distension-mediated contractility. But yeah, but seeing these nice, very normal anterior contractions.
And can you differentiate between the crural diaphragm and the LES?
Yeah, you can sometimes, and sometimes
Is this the crural diaphragm at the bottom?
this may be. I don't know if she maybe generated actually a kind of hiccuped herself into a small hiatal hernia.
You should see it better, no? Because the crural diaphragm will contract.
So in the beginning, it looked like they were both at the same time, then at the same place. Then she started to hiccup, and here you can see a differentiation in two. And I wouldn't overdiagnose, and I think we both would not overdiagnose, but it's possible that this is the crus and this is the sphincter.
Yeah, I think with respirations here, these are actually the crural contractions within the.
Okay.
So, yeah, so I think they're still overlapping, and yeah, there's not a hernia. Yeah, this would be the crural contraction here. But one thing we do notice actually, and we see this very typical with normal contractility, is the contractility is actually synchronized with respirations. So obviously the hiccups disrupt that respiratory pattern a little bit.
So what I like to do, I don't know how you do it, Dustin. I like to pause at. I like to look. I mean, let's look at this area, right? Because that's the sphincter that many people are interested in. That if this was an achalasia patient, right, we would look both at the peristalsis, but also at the sphincter. And you have the opportunity to pause the image here. You can also save images if you like. And I sometimes have to look at and study this area a little bit. The value here is giving you the lowest DI. Now in a patient that has contractions, this is you have to use this carefully because it shows you wherever the lowest DI is along the curve, right? So at this instant now, you can see it's always showing me a low value, but this is coming up. So this is not the sphincter. So you really have to look at the reference area that you're interested in, which right now is here. And you have to delineate basically the highest DI out of those values, which is around 6 to 7 from what I've seen so far.
Yep, yeah, and so yeah, and I'm kind of the same. I'm just, instead I just kind of focus in this area here, and really based on my positioning that I can see at the end of the contraction here, you get that EGJ that's localized right within this area, and even here, I mean, this is obviously very, very normal EGJ opening. Our diameter at this point is 21.4 millimeters. I'm always kind of incorporating all the factors into play though, so looking at the diameter, 21, pressure 46, so a good adequate pressure here. And then obviously the distensibility index is the composite measure that brings in the cross-sectional area divided by pressure. And in all those pieces together here, I mean, this is obviously about as normal as you can be. I mean, nice DI at 7, diameter is well above 18. So yeah, this is, if she was having dysphagia, I would not think it's related to anything related to motility here. And really for a patient with even some reflux symptoms, pretty classic finding here. And really the great thing about this flip, normal EGJ opening, normal rack pattern, sort of normal contractile response. I mean, if for some reason somebody wanted to do a manometry on this lady, the chance that it would show a major motility disorder is on the order of 0. So this is somebody that if there was some concern about motility, I think you could really spare her from a manometry, and instead the management algorithm would really focus on reflux, or if not reflux, then more of a functional syndrome.
The normal values are established by a lab, or do you have to establish them yourselves, or can you take them like they are?
Yeah, so I mean, I think we're the ones who have done the largest cohort of normal controls, and yeah, I've reported on 35 people. All those controls were done with sedated endoscopy, so at least from a sedation standpoint, that's been fairly well characterized. Yeah, but I think that also, even one of the things that came up yesterday is kind of looking at, do you look at normative values in a lower range to identify abnormality, or do you look at disease and look at the upper range of normal? And so, and really some of those factors that we've seen there that will really help differentiate normal from achalasia in particular is using a DI value, and we, less than 2, definitely comfortable that that's abnormal. Above 2, kind of more normal on the EGJ DI standpoint. But we don't use any measure in isolation. And so we always do look at the pressure, and especially looking at the diameter. And we do incorporate the maximal EGJ diameter that's achieved here. Normal value there is going to be really more than 18, but differentiating from disease greater than 16 is usually pretty good from for a normal confident value. And that's even where we now define normal EGJ opening on FLIP if there's a DI greater than 2 and a maximum EGJ diameter that's greater than 16. And those two values together can give you a lot of confidence that you've ruled out achalasia in particular as a diagnosis.
So yeah, from a European standpoint, definitely take both values together. We do see a number of patients, especially type 1 achalasia, that do have a DI of 2.8, sometimes even 3.1, 3.2. So the original paper was 0 to 2 pathologic, 2 to 3 borderline, above 3, and I think that holds still true also from our clinical perspective, so we see the same.
Yep.
And the diameter is a nice adjunct parameter, right?
Yep, exactly, yeah. And that's even in that scenario that you described there, usually with even achalasia, even if the DI is 3 or even 4, that's going to be very much a pressure-mediated value. It's usually because the pressure is on the low side. And when the esophageal body is dilated, sometimes that pressure can be a bit low. But yeah, when you bring in the diameter, though, those achalasia patients, their diameter values are usually still quite abnormal, and definitely well less than 16, usually less than 12. And that's, yeah, we kind of have that middle zone that we call a borderline EGJ opening. Sometimes that is a finding that you may need to correlate with an additional test, but sometimes that additional test is the endoscopic appearance, sometimes a time-bearing esophagram, sometimes a manometry, all these things. Sometimes you have to bring in these factors together. Yeah, because in the end, I think you just want to be confident in an achalasia diagnosis, making sure that you're either effectively ruling it out or, on the other side, obviously effectively ruling it in as well. And if there ever is some uncertainty in the middle.
Normal values for the distensibility at the LES. What is the normal value?
The normal value?
Yeah.
Like I would seen in asymptomatic controls is actually greater than 3.
3.
Yeah,
And
but
achalasia?
if you look, achalasia, it's less than 2.
Yes.
Yeah, but don't think about one number. Think about multiple numbers. Yeah, so DI and diameter,
Yeah.
and then often here we would go to a 70 ml fill volume, except for the fact that when the EGJ opening is.
Maybe for the sake of time, we go to the pylorus.
Yep, we'll empty it now and go to pylorus. Yeah, when really normal EGJ parameters are already achieved, that's often with time we don't have to go to the 70 ml fill volume. Certainly if there is any concern for reduced EGJ opening, borderline EGJ opening, that's where kind of maximizing the fill volume of the FLIP can be very useful to help open up the EGJ. But yeah, but in this finding, as normal as that was.
Maybe let's just hear from Daniel how he manages to enter the pylorus.
Yep, exactly. Yeah. So right now we're emptying the FLIP, and yeah. So Daniel will demonstrate now passing the FLIP past the pylorus.
Yes, we're deflating now. We're now moving on to the pylorus. I mean, we can obviously discuss the measures again for the next patients on the esophagus.
Yep. Yeah.
And
Do you want this all the way empty, or do you
first.
ever pass the FLIP with a little bit of fluid still inside?
Yeah, actually, I prefer to have some fluid inside because it gives the balloon a little bit more stability.
Okay. Where would you like me to stop it?
Actually, don't. So just go down and I'll see how it goes. So
Okay.
basically, I can, because every patient's a little bit different, and I always basically advance right away. I want to be below 40 because I don't want to pre-dilate the pylorus, because we know from studies that if once we've gone up, if we go down again, the values are going to be higher. So you really should take your first measurements. And maybe another thing is, don't measure with, at least not in the esophagus, with the scope in. We looked at that, and there's actually a significant difference in your values if you have an endoscope straddled over the upper esophageal sphincter.
But in pylorus you can say in
Yes,
so much.
you can stay. We didn't look at that specifically, but I mean, it's a different organ, right? One is a tubular organ, and the other one is a reservoir organ. But I try not to have too much air in there. So I'm advancing the scope together, kind of like in a Seldinger technique, into the pylorus, and then I make it so that I maybe have.
Non-traumatic, right?
Say what?
The tip is non-traumatic.
Yes, I like to think so.
Yeah, it's a floppy rubber tip. Yep.
It's very floppy, it's very soft. The Endo-FLIP is much harder than the Endo-FLIP. So the Endo-FLIP really, even if it's fully inflated, it's still very soft. So that I don't see any even possible danger with it, to be honest. The scope itself is much more dangerous. So I'm advancing this together with the balloon around the second part of the duodenum, and then go down into the third part. And this needs a little bit of practice. I'm going back, holding the scope in place. We're now fully deflated, right, Dustin?
Yep, it's completely empty.
All right, now I try to get it in a little bit. I want to have 1/3 in the stomach and maybe 2/3 in the small bowel. This looks rather okay. So let's go on. Let's inflate.
And if you have a patient with a difficult duodenum 2 or 3, do you help yourself with a forceps or not?
Yes. Sometimes I have to use a forceps to get it around, especially if I treat. Maybe another thing is, if you do this, the balloon can kink. Also, the wire can kink. So you have to be sure not to have too much wire left over in the stomach. If you do, you will hear a horrible sound from the machine. there's no pressure sensor in the machine cutting it off. So you need to identify that sound and stop the inflation. Okay, we're going up to 50 now, please.
The patient is on tachycardia. Is this pain or is it just maybe light sedation? Tanya,
Well,
does it feel pain?
no, this is not painful except if I advance or push anything in the pylorus, I'm going to have, I would say, a larger strain on the pharyngeal region than usual, right? Because the stomach angulates, so I need a little bit force with the endoscope. But I guess this is a sedation issue.
So we're at the 50 ml fill now.
So we're at the 50 ml now, and this looks, I'm rather comfortable with this position, right? We see it in the upper third. So this is this part which is in the small bowel, and this is the part which is in the stomach. And you can see me making a dent a little bit in here. So I'm gonna try to go away, and as you can see that it opens. So I don't want to have my scope on the flip if I do any measurements. I'm gonna try to get back a little bit. As you can see, I'm a little bit limited here by space, but that's okay. And sometimes, you know, it moves a little bit back and forward. Sometimes you have patients that have retrograde peristalsis in the small bowel, vomiting basically, trying to get it out. Sometimes they don't. And also, this is beautiful. I can very nicely inspect the pylorus for anything, right? This is a beautiful image. This is through the balloon. So this is also very elegant if you look at anything there. I mean, this looks like a small, even a tiny ulceration or something, or erosion that I haven't seen before. I don't think it was there before, okay. Okay, very nicely. So now you can see it even better, and you can obviously also document that. All right, so I'm not super happy with the placement, but it's okay for now. So we have 50 ml in. We have a diameter of around 12.2. We have a distensibility which is rather low, 6, at a balloon pressure of, let's say 15 to 20. So I'm not super happy yet. So you can see some antral contractions here. This is an antral contraction. This is something you have to account for, obviously. So you have to give it a little bit of time. But I would be okay. And again, as Dustin pointed out, it's very important to have the right filling volume. So I would like to have a little bit more filling. So let's please go up to 60. Yeah. But you know, the stomach is much less, has much more cycles, right? It has a different motor background than the esophagus. So you might be stuck in an MMC3 activity or somewhere out of that. Yeah, and obviously, I mean, it's still a sensitive organ, right? Also, especially the proximus part of the small bowel. So very often it reacts.
Because this, you know, the type antropyloric duodenal motility, we measured once with EPMTs and stuff. Can you make any correlation with that? Is it the same as you're observing antropyloric duodenum?
Well,
265?
Trying to get the. Yeah, so we're not getting it. So let's try to get it here. So I always try to hit the point where I get the highest value, right? And then I really try to pause it to get the values down. And I usually work with not such a prominent colleague, but someone who writes also down the values. I think this is important that you have something to report later on. There's no output from the machine, right? You have to do this yourself right now. So this would be a diameter of 12.5, rather low. Distensibility of 6.5, but the balloon pressure, in my opinion, I don't know what you think, Dustin, is still not where I want it.
It's a bit low, yep.
It's a little low. So let's do something about that.
All right, so I'll go to 65 then.
Yeah.
Can I ask about slippage? You're not kind of holding the catheter. It doesn't tend to slip. Is the waist just holding in, or?
I think at this point there's a lot of fluid in there. Yeah. In the esophagus, it definitely will pull at times, and so there is a little bit of interaction to try to adjust the positioning. The nice thing with the flip, though, is that you do always have your anatomic landmarks, so you can reposition it to kind of maintain that as you're going through. So here you're at the diameter of 14, the DI is still, it's around 6, and pressure is 24 only.
All right, so this is our first meaningful, I would say, measurement. Diameter 13.5, distensibility of 6.1, balloon pressure of 24. So that's all right. We're going to do 70 as well, but the distensibility is going to be lower with 70. Right? I mean, that's what's going to happen physiologically. So to be honest, this is on the tight side, which is an analog to the visual impression of the pylorus. So I mean, the values here are not as established as in the esophagus, right? Looking at the data that other groups have found, both from the United States and from France especially, I personally feel that below 8 is pathologic, between 8 and 10 is borderline, and above 10 is normal. Here we
Yeah,
are at
6.
6.1,
Yeah.
so this would be pathologic.
Okay, so she has.
All right, so should we go to 70? All right, we'll go up.
That's what we want.
Can you change the colors that you see the low amplitude is better, or you stuck to this image? If you can change the color scheme that you see better,
You adjust the scale
low
to change the
amplitude,
colour.
No, the color scale is fixed.
You can't change it, like in HRM.
Nope, no. This is mostly a display. There's very little interactive functionality with it. Yeah, a few pieces there. You could change the language or the measures, but it's mostly just providing values at this point.
And you
So this is a retrograde contraction, which you sometimes see from the small bowel. Patient is trying to get rid of it. So it's rather similar, I would say. 14.8, 5.9, balloon pressure 29. The balloon pressure is not very different here at 65. Again, the 65 step is something that we came up with because, again, we needed this critical balloon pressure. So it's mostly either the 60, the 65, or the 70 that will give you an answer. So here I'm happy with the 65, but also the 70 goes in the same, right? Clinical outcome 14.8, distensibility 5.9, and then there's 29. There's some normative data from a Chinese group that said that 17 is kind of like normal, but at a much lower balloon filling. They reported lower balloon fillings, 40 and 50. So I'm a little bit hesitant with that. I believe the gastroparesis data that are out there, and I would say, again, this is a tight polyurus, which fits the gastric remnants. It also fits the disease. It fits very well the drug, right? GLP-1. And also, we saw this small erosion indicating probably more a mechanical stress in that region rather than HP. I'm sure you've excluded the HP, right, Helen?
If she wants to keep the drugs and stay better, would you perform a dilatation?
Wow, now you're killing me. This is a very difficult question.
Daniel, should I take this down?
Yes, please. So we're going to deflate and so again, here you can take I also like to take a picture at the maximum dilation to see where the pylorus is, and this is very well possible.
also with a volume of 50 with pylorus.
I don't do pylors.
Okay.
Dusty, have you done pediatric stuff as well? I'm a pediatric.
No, I'm an adult gastroenterologist. So some teenagers, but yeah, and I think even there, I think some of the, at least the big kid data is probably pretty similar to. But we have been working with some of our pediatric colleagues, to try to see where FLIP fits in.
Yeah.
Obviously, from a tolerability standpoint, I mean,
Yes, the values,
appeal
all the values
galore.
are very much
So,
linked to the
yeah.
volume inflation. So you have to make sure to have a critical inflation. In our opinion, you have to have at least 20. In the previous literature, it was 15. Now it's 20. It doesn't even like 25 to 40. I like 25 to 35. That's where we feel the best fidelity in terms of correct values of what you are trying to measure is there, right?
The esophagus, it would be like 40 milliliters balloon, or?
I think with the 16 centimeter flip, it's usually you get to those values around 60 ml. And that,
60.
the 60 ml fill. And that's why we really preferentially use that 60 ml DI value in the esophagus. And it's also even just from the performance of the flip device, it does require a fair amount of fluid to actually start to distend and exert a little bit of that pressure with distending the whatever sphincter you're in.
But the more
wait.
filling you have, the more distensibility usually, no?
It should be relatively balanced. I mean, that's one thing with the flip as well, is that the bag itself is infinitely compliant up to a point. And that point with the 16 centimeter flip is 60 mLs. There's another...
For the pylorus, you take the same filling, or?
it's the relative amount of filling within the flip bag.
Generally, a little more.
More than 60.
Well, no, the thing is, the esophagus is a tubular organ, right? So you have a lot of material around it to make it tight. And in the stomach, you have at least 1/3 of the stomach, and then the rather floppy small bowel, right? So you need, I would say, on average, 10 ml more to get the same values.
Yeah, and that is a nice thing with with the flip is, yeah, once you do start to actually overfill that bag, you actually do start to exert a little pressure by the filling alone. But yeah, but like Daniel's saying, sometimes you're looking at necessarily at the pure mechanics of the organ. You're looking at the response of, you know, the kind of the dimension pressure relationship. And so by exerting a little extra pressure, sometimes you can actually, you know, somewhat stress that sphincter to measure the distensibility.
Is it essentially, is it a barosted kind of bag?
It's not a Barricade kind of bag. It's a volume controlled filling. So it's not based on pressure.
So the
But you can,
pressure rises,
yeah, so you measure the pressure, but you can somewhat control the pressure by overfilling the bag to a point. And that's, yeah, a little bit what Daniel was saying, that, yeah, with the 65 ml fill, the 70 ml fill, you are generating a little bit extra pressure that allows you to really look at the dimensions at those points.
So basically in this patient, in the end, we had normal esophageal tubular activity. We had a very normal EGJ, even for a reflux patient, because sometimes it means she didn't have an overt hiatal hernia, right? And sometimes we see like a distensibility of 10, 12. That probably goes more towards the reflux realm in terms of too floppy, right? And there's some data on that. And the pylorus is tight.
Yeah, yeah. Though I think even like with the manometry data grid, I mean, obviously there is a increased susceptibility when you have a hypotensive LAS, when you have an increased distensibility of the EGJ. But most GERD patients will actually have normal EGJ distensibility. So yeah, I think from a GERD standpoint, this actually is a pretty fitting motility pattern. Just like most GERD patients will have a normal manometry, most GERD patients probably will have a normal flip. Yeah, sometimes maybe a little higher levels of impaired secondary peristalsis, though not the case here.
And also, I mean, she said a clinical picture, right, of responding well to the Dexilant, but still having some volume. Now with her drug, which to be honest is an automatic drug to cause gastric emptying delay, plus the metformin, which is also then a drug that causes additional symptoms, right? It's very well possible that she actually does have some volume that comes up despite her not having a primary problem, neither at the EGJ nor at the esophagus, right? At the tubular esophagus.
I wouldn't do anything.
So we would decrease the drug if that's possible.
Increase the
Decrease, or try to get rid of it, ideally, to see if her dyspeptic symptoms get better. I would probably halve the metformin to twice a day for 500, except of one time 1,000 in the morning. See, that would be my first take, and stay on the Dexilant and see how
And lose weight.
how that works. Yes, that's going to be probably the toughest part, because actually she's been recently gaining a little bit under Ozempic. So probably if we take her off or reduce the dose, unfortunately it'll go in the wrong direction. So it's balances and checks.
In what point would you dilate?
Well, I mean, if she is, I don't know how you think about this. And if I cannot get rid of the drugs and she's severely compromised, then I would do it, because the morbidity, in my experience, is low. I would try it. The thing is probably also the body of the stomach is also a little bit, not contracting well. But I mean, we identified one possible target that we can treat, right? There's nothing that we can do endoscopically really about the stomach itself. So yes, I would go ahead if her symptom load is suggestive of that, and if I don't have any medical other way of getting her better.
Do you know whether different GLP-1 analog have different kind of motility effects? So should we switch the drug if we can, or?
I don't think so.
Not that I'm aware of, though.
No.
As an esophagologist, I'm stepping outside my comfort zone.
Yeah.
And your goal would be distension 6 or something like
Well, to be a normal pylorus, or the people that I've treated and then rechecked, basically, in her I would like to see above 8, above 10 normally.
above 8 even.
I mean, I'm very sure if I would dilate her now, I would measure probably 11 or something afterwards, just on the ones I've done. But this is going to retract a little bit. There's also healing tendency of the pylorus, so it'll come down again.
How much did she have?
She had now 5.9 or 6, 5.9.
Okay. Thank you very much.
Do you do it in tube patients as well? Patients with the tube down?
Oh, they have an ET tube? Yeah, I have no No,
And passing, there's no particular.
goes on pretty.
Children,
In children, yeah. Easy. Yeah, no, and even with passing the flip is very simple. I mean, it's if there is ever any issues, you're not sure positioning. I mean, you have an endoscope, and so it's very easy to look at it, visualize it, and get it positioned. But I've definitely done it in intubated patients, and it goes down very easy.
And obviously, you always keep your endoscope proximal to the balloon.
Yeah.
Yes,
for the most
not
part,
distally.
Yeah, if you need to, I mean, sometimes, achalasia patients with some tortuosity or even extreme infiltration, you have to race to the front of the balloon. But the nice thing about the atraumatic tip actually on the flip is that you can grasp it with a snare or a forceps and actually use that to direct it through. I say I very rarely have to do that though, even in very dilated achalasia patients. Usually with a little nudge, maybe at most, it pops through the sphincter pretty easily.
Okay.
Yeah.